Hello everyone and welcome to the first lesson of the comprehensive research course from idea to publication. In the first lesson, we'll talk about how to start a research project, and here are the lesson objectives. So first we'll talk about study design, then we'll talk about the research question, research ideas, how to do a literature review, the IRB process. What are the different study designs? So you'll see that whenever you're designing a project or thinking about a research question, you can approach the same research question into multiple research designs, multiple study designs. And I'll talk here about the main ones that you have as an option when you think about a research study, and we'll mention briefly the other study designs that are available out there. So the ones that I will be covering in details are the cross-sectional studies or survey studies, the case series, case control studies, retrospective cohort studies, prospective cohort studies, and randomized clinical trials. Let's start with cross-sectional or survey studies. So cross-sectional studies are like a snapshot. They give you a picture of what is happening currently. They don't look back in the past, they don't look in the future. They are an assessment of the current prevalence of a disease or a risk factor. So let's assume that we have a group of patients and they use different drugs. Drug A, drug B, and drug C. And some of these patients have heart failure, some do not have heart failure. So what we do is we go and ask patients what type of drugs they use, A, B, or C, and whether they have heart failure or not. And then we try to assess whether there is a relationship between having heart failure and using certain type of drugs. The issue with this type of studies, the limitation of cross-sectional or survey studies, is that you can't establish causation. You can't tell whether heart failure started before the use of the drug or the drug is the cause of heart failure. The same example applies if you're trying to assess the use of cigarette and development of lung cancer. So you go and do a cross-sectional study, a survey study, and ask patients whether they have lung cancer or not and whether they are smoking. If you find, for example, a relationship between smoking and lung cancer, you can't establish the causation. You can't tell whether smoking caused lung cancer or whether those who had lung cancer started smoking after the diagnosis. So this is the limitation of cross-sectional studies. You can't establish causation. They're more of a way to establish associations and then study the same research question in a more complicated study design. So you take a snapshot of the current situation, the risk factors, the outcomes, and then you try to find associations and maybe study that in the future in better study designs. The next type of studies that we will talk about is case series. So case series, you have a group of patients, let's say a group of patients over 80 and they use drug A. And we want to see the efficacy of that drug. How many patients develop heart failure after they start drug A? Is it decreasing their symptoms compared to before using the drug? But the limitation of case series is that you don't have a control group. So we're not comparing patients who are using drug A to patients who are using drug B. We only have one group. So drug A, and then we follow these patients and see if they develop the outcomes or they have side effects. For example, let's say you're having a group of patients who have pancreatic cancer and you developed a new surgical technique to treat pancreatic cancer. And then you start doing the surgery, you had a group of 100 patients or 200 patients, and then you see their outcomes after 1 year or 2 years or 3 years and see if they're alive, if they're having side effects, if the surgery is successful. But you're not comparing your technique to another technique. It's only one technique, it's only one group, and you're seeing the outcomes of that. So this is case series studies. You have one group of patients, you don't have a control group, and you look at the outcomes after you start the risk factor or the medication or a surgical technique. The next type of studies is called case control studies. What does case control mean? So case control studies starts with the disease or starts with the outcome. And in our example, we're talking about heart failure. So let's say that we have two groups of patients. One has heart failure and the other does not have heart failure. And we start with the disease. So we start with those who have heart failure, no heart failure, and we look back in the past to see who used drug A and who used drug B. So for case control, in comparison to case series, they have a control group. Now we don't only have drug A, but we have drug B. And this is essential to have a control group. You might ask, what is the importance of a control group? The importance of a control group to see if your treatment or your surgical technique or the risk factor is actually different than what is available. For example, you might find that drug A is working. There is a good amount of response after that medication. But the question that we should be answering is drug A better than drug B? Because what is the criteria that drug A is successful? You always need to compare something to something else to know if it's better, if it's worth, if it's similar. So the same with surgical technique. Maybe your technique is good, but is it better than what is available? Is it better than another technique? So you always, in research, try to have a control group to see if your treatment is actually working, if your surgery is actually working. That's why it's very essential to have a control group, not only assume that your treatment works by itself. So back to case control. In this case, for case control studies, we have a comparison group, but we don't start with the risk factor or the medication. We start with the outcome. So we go back in the charts and we see who has heart failure and who does not have heart failure. And then we go back in the past because the exposure to the risk factor or the medication should precede the outcome. So we go back in the charts, find those who have the outcome, go back further and see who used drug A and who used drug B and try to find the association between the two. This type of studies is very important whenever you're having an outbreak of a disease. So you start with patients who develop diarrhea, for example, patients who didn't develop a diarrhea, and then you ask them if they ate a specific type of food or if they went to a certain restaurant, and then you try to find the association. So that's what case control is very helpful with at outbreaks, but it can be also used for other research questions. The unique thing about case controls is that you start with the disease or the outcome, and then you go back in the past and see the exposure or the medication or the surgery that was used. Now moving forward to retrospective cohort studies. In retrospective cohort studies, you have patients who had used drug A, patients who used drug B, and some of these developed heart failure, some did not develop heart failure. But the difference between case series, case controls, and retrospective cohort studies is that for this type of study, you start with the exposure, you start with the medication, with the treatment, and then you look for the outcome. For case control, we started with the heart failure, no heart failure, and we looked back in the past and saw who had the exposure. Here, it's the opposite. We start with the exposure and we look afterwards who developed the outcome. What is the difference between retrospective cohort and case series is that we have a control group here. If you remember, for case series, we have drug A and we look to see who developed heart failure and who did not. But for this type of study, the retrospective cohort, we have a comparison group. So now we can tell whether drug A is better than drug B, drug A is similar to drug B, and this is a better study design because now we can confirm that drug A is good or drug A should not be used. You see here next to drug A, drug B, and next to the outcome I have past and present. That means that for retrospective cohort studies, everything is already collected, everything in the charts. That's why whenever you think about this type of studies, the information should be already in the charts. So what you do is, let's say now we are in year 2021 and this is the present. You go back in the charts and you say, I want to look at patients from 2015 who used these two type of drugs and then follow these patients until 2021. So you start with 2015, for example, in the past. You look in the medical charts who used drug A, who used drug B, and then you follow them across the years until the present, which is 2021, and see who developed the outcome and who did not. This is what differentiates retrospective cohort studies from the next study design, which is prospective cohort studies. Prospective cohort studies have exactly the same groups, similar outcomes in this example. So you have drug A, drug B, and you're seeing who developed heart failure and who did not. But the difference is for the exposure, you start in the present and you follow patients in the future. So in this example, we are in year 2021. So we start recruiting patients. we start bringing patients and giving them drug A and drug B, and we follow them in the future from now until maybe a year or 2 years or 3 years based on the study, and we see who developed the outcome. So in this study design, we don't have the information in the records. We have to actively collect it, actively assign groups, follow up on patients, and see who developed the outcomes or not. So this starts in the present and goes in the future. Retrospective cohorts, they start in the past and go to the present. The other difference between retrospective studies and prospective studies, especially for medical students who are trying to do research, is that prospective studies are way more complicated to do. Because as you can see now, retrospective studies, all the information are in the medical records. So what you need to do is just go back, look in the charts, paper or electronic, and collect all the data. Everything is already there. You just need to go and collect it and design it in a paper and submit that paper. For prospective studies, you actually need to have a team to follow up on patients. All the information is not there. It's going to happen in the future. So you might need a year or 2 or 3 to complete the study. So that requires a lot of time, a lot of effort, a lot of money that needs to be spent for a prospective study to be completed. And that might happen after you graduate from medical school or after you finish residency. It takes a long time. While on the other side, for retrospective cohort studies, it's much simpler. Everything is there. So if you spend maybe 3, 4, 5 weeks, spend hours to collect the data, it's already there. You just collect it. Here, you need to wait until the outcomes develop. This definitely is a better study design. It leads to higher level of evidence. But on the other side is that it takes time and it might not happen during your research year or during your medical school. And now at the top of the pyramid is the randomized clinical trials. Randomized clinical trials have a similar study design to prospective studies, is that you start in the present, you give a group A certain drug or certain medication and group B a different type of medication or treatment, and you follow them in the future to see who develops the outcome. The only difference is that here the assignment of drug A versus drug B is random. So for prospective studies, physician A might like certain type of medication and they give patients with certain BMI or certain age this medication versus the other. So there is selection bias. The physician decides who to give the medication to, or the patient might decide. They might have a preference. In randomized clinical trials, it's not the case. The assignment is random. That's why it's called randomized clinical trials, because neither the patient nor the physician choose who gets treatment A versus treatment B. So it's totally random, and that's the best studies design and leads to the best level of evidence. Why? Because sometimes you might be giving medication A to sicker patients, and you might find, you know what, drug A is not as good as drug B. But the reason why we found that is because we're giving drug A to sicker patients. It's not because drug A is bad. It's only that the patients that are receiving drug A are worse patients. When you do the randomization and give patients a random choice of drug A, drug B, here you're removing all these biases that are associated with selection bias. That's why this type of studies is the best. However, it is way more expensive to do. It requires a lot of time to do the IRB, the consent, a lot of funding. And as a medical student or as a resident, it is unlikely for you to lead a randomized clinical trial. You might be helping as a coordinator or trying to do some consents for patients, but it is unlikely that you would be leading a randomized clinical trial. That's why most students would be focusing on case series, maybe retrospective cohort studies. If you were able to lead a prospective study or a randomized clinical trial, that would be amazing, but it is difficult and it's very time consuming and it requires funding. Now I want to talk about other study designs briefly. I'm not going to go into details of these during this course, but I'm just going to touch on them so you have an idea of what these stand for. The first one is qualitative research. Qualitative studies, they try to see how patients perceive treatment, how they perceive outcomes, and they might lead to developing a validated survey. This is a very complicated process. It starts with interviewing patients, maybe 10, 20, 50 patients, and you record all the interactions you have with these patients, and then you try to narrow down the things that are important for this type of disease and try to make maybe 100 questions, and then you narrow it down using statistical analysis, more discussions, to maybe 15 questions or 10 questions that are important for this disease, and then that creates a validated survey to assess the outcomes, for example, after hernia repair or after different type of surgery, and see the patient perspective of that. So qualitative studies are much more complicated than the other type of studies. They require a team who is experienced with this study design, and if you're interested with that, that is totally different than what I'll be talking about in this course, and that type of studies is not covered in this course. The basic and translational science studies will also not be covered during this course. That involves animal studies, cell studies, anything related to lab research and is not clinical research. Case reports and viewpoints, I've already discussed that in detailed YouTube videos on my YouTube channel, and I will leave the links for you associated with this course so you can have a look at them. Many of the things that I'll be talking about when writing a manuscript will apply to both, but if you want to write a case report, write a viewpoint, you can use the information available in my YouTube videos, and they are free for you to have a look at. My recommendation is you can start with case reports, viewpoints, but if you have the opportunity to publish original research, case series, retrospective studies, prospective studies, it's definitely better to use these type of studies compared to case reports and viewpoints. So when I started my journey, I started writing case reports. My first paper ever was actually a case report, but during now my 3 years of research, I only wrote that case report, the first one, and another one. So I transitioned towards doing more original research. So start with them, but definitely try to transition to original research. Database studies are a very cool type of studies because the data is already collected. So all the studies that I'll be talking about in this course, you actually have to go and collect data either retrospectively, which means you go to the charts, or prospectively, which means you have to interview patients, do follow-ups, which is very time consuming. The cool thing about database studies is that the data is already collected. For example, Market Scan database, they have data from patients around the US, millions and millions of records. And the way that they get this data is from insurance claims. So there is a special way of getting this type of data. There is a code that you need to use. So once you learn it, it becomes very easy to get the data, but you need to have access to these type of databases. Some of them are very, very expensive. Some of them are paid through the institution. So definitely if you're doing research in an institution that is well funded, you can ask what databases does your department have access to. Sometimes your department might not, but another department within the same institution might have access to a big database. So you can reach out to them, to the people in other departments, and try to collaborate to do these type of studies. The only unique part is trying to find the codes and what each code stands for. And people who have access to that generally are experienced with this. So you might have the idea, you reach out to them, and they can help you get the codes and get the data, and then you have to analyze it. The analysis is the most complicated part for database studies because you might be dealing with 100,000 patients or 1 million patients. But on the other side, if you get to manage these data and have a cool idea to publish, it will be published in a very high impact journal because you're talking about patients across the US, not only from one single institution. But many of the principles that I'll be talking about in this course will cover database studies. I will not cover how to get the codes and the details of managing the big databases, but many of the aspects related to how to write the paper will apply 100% here. Bibliometric analysis studies will also, many of the principles I'll teach will apply here. Bibliometric analysis mean that you assess published articles. For example, what is the publication rate of different institutions, or gender differences in publication rate in plastic surgery or general surgery or cardiology. What is the percentage of abstracts that are presented get published? So some things related to publication characteristics, impact factors of journals, not necessarily patients. Now systematic reviews. Systematic reviews will not be covered in this course because they have a totally different approach than original research. The idea how to write the introduction, methods, results, conclusion, discussion will apply because I'll be talking about that in details. But the study design of a systematic review is totally different than original research, and I will cover that in a separate course. What systematic reviews stand for? There is a systematic way of collecting all the studies that assess a single topic. So let's say you're trying to assess differences in outcome between drug A and drug B. So you go and look in the literature. You don't look at your patients. In the literature, all the studies that compared these two drugs, literally every single study, you cannot exclude any single study unless you have that mentioned in your exclusion criteria, and you try to see which is better based on published data. The positive aspect about systematic review is that if you're in an institution that does not have access to original research, or you don't have complicated patient information or complicated techniques, you can be literally anywhere and be able to publish this because you're using published data. You're not using your own hospital. You can even be in not in an academic hospital. You can be in private clinic or just not in medical school and be able to publish this type of studies because they don't require patient information. So that's the positive aspect about systematic review. But the negative is that since they don't require patient access, anyone can do them. It's very difficult to find a topic or an idea that nobody has talked about previously. So if you find a new idea that nobody has published and is interesting clinically, systematic reviews are very good to go. For me personally, I did a lot of systematic reviews in the beginning, but as I approached more original research and I had access to so many patients, I preferred to use my time to publish original research rather than systematic reviews. But for example, if in the future, I don't have access to these type of patients, I would definitely go with systematic reviews. Review articles, on the other hand, they are kind of a summary of a topic. So let's say you're trying to do review articles on the effect of vaccinations on COVID-19. So you don't do it systematically, which means you don't go and look at every single article that talked about vaccination for COVID-19. You look at some and provide your own experience in a review article, like a summary or presentation to people to read about. They are the easiest to do. They are much easier to do than systematic reviews, and they don't require patient information or access to complicated data or patient information. On the other hand, usually review articles are solicited, which means the editor-in-chief asks somebody to write the review articles for them. So it's not like everybody can write a review article and they submit it to a journal and they will get accepted. This is the thing I learned by my experience, is that they are solicited, which means the editor-in-chief asks people who are experienced with this type of topic. For example, the example of vaccinations and COVID-19, the editor-in-chief looks who is experienced in vaccinations and COVID-19, and they ask them to write a review article about the topic. That doesn't mean that if you have a very cool idea for a review article and you submit it to a journal that it will not be accepted. It's just hard. So instead of, for example, 100% chance, you might have 20% chance or 30%. These are just estimations. But what I'm trying to say, it's not easy. Even if you find a review article about the topic, that doesn't mean if you write the same single one, it will be accepted. So if you're trying to write a review article, always make sure that whether this is invited or not, and whether this will be accepted in the journal. Because review articles, even though they're not hard to do, they take a lot of time, especially if you want to write a good one. They might take you 2 or 3 weeks. So you don't want to be spending 2 or 3 weeks and then submitting from a journal to another and all of these journals rejecting the paper.